Please.
Hey guys, this is Roberto. I think we met in the last one of the first cardiology fellows, first year cardiology fellows. So as you can see, I didn't update the first slide. Anyways, um, so in here we're going to do a pre-assessment, but I'm not going to use the interactive Kahoot thing because I would need like another computer setup. But in general, I want you all to just keep in mind what you picked in the pre-assessment, and then in the post-assessment, we'll go through together and make sure that you understood why the right answer is the right answer. Okay. So in this one, nobody should state anything in the chat yet. It's just 4 questions. Okay, so 45-year-old male, asymptomatic, but with poorly controlled hypertension. Just give you 30 seconds or so. These are the potential answers that I'm giving you. Okay, so we're gonna go through to case number 2. Okay, I hope everyone picks something and just write it down. So this next one is a 59-year-old female, hypertension, diabetes, presenting with palpitations. These are your potential answers again. Okay, we're gonna see the third one now. So 53-year-old male, hypertension. It's an a follow-up visit, but with occasional shortness of breath. There are potential answers. It's not hypoxemic if you're thinking too much about it. Okay, so we're gonna go to case 4. 61-year-old female presenting with acute decompensated heart rate. These are the potential answers. Okay. So anyways, in each one of these sessions that we will do from now on, depending on how many we do during this year, but what I try to do is just to have a pre and post assessment, so that way you see, or at least you think about if you knew already the material before, compared with the post assessment, or the point is, if you already knew it, at least from the lecture, what I want you to take is how you can make it more efficient to you to get to the diagnosis if it took you longer than expected. But in general, there will be a pre and post assessment. Everything will be just cases, because that's what you want to see in an EKG conference, right? You want to see EKGs. And then each one of these ones will have a conclusion slide, but some high yield material will be shared either at the beginning, in the middle, or after each one of them. And at the very end, take home messages. Okay. So narrow complex tachycardia is very important, because in general, I mean, as you know, arrhythmias, you can see in this schematic, it's just tachyarrhythmias on top, right? But they can come from many different things. It can be just from increased automaticity, from either the SA node, which would be sinus tachycardia, or just latent pacemakers, which would be like junctional tachycardia. And then abnormal automaticity, when something that shouldn't take over takes over, for example, ectopic foci, right? It can be from the atria, it can be from the ventricle. Okay. Obviously, as we're talking about narrow complex tach, we won't see any ventricular tachyarrhythmias in this particular one. But then you can also have trigger activity, and you can also have your most common one, which is basically reentry, right? Reentry, we'll talk about it more when we do white complex type, but it can also happen, as you know, with atrial flutter, AFib. Okay. So, anyways, talk about narrow complex tachyarrhythmias. This is your differential. So the first thing that you want to do when you see tachyarrhythmias is you want to first categorize this into narrow versus wide complex, and you're going to just use 120 milliseconds of the QRS duration. After that, for both, you want to just do regular RR interval versus irregular RR interval. Now, the irregular ones are the easiest ones. So the irregular ones, you have here only 4 differentials. Okay, you have your sinus tachycardia with PACs, which is the one that you'll see the most, especially in telemetry, and then we get consulted because of is this AFib or not, and many times it's just because there's artifact also, so you cannot really see well the P waves. But sinus tag with PACs is very likely that you'll see it, and very commonly misclassified as AFib. And the importance here is that if you say that someone has AFib and people believes it and then carries it as paroxysmal AFib, and the patient might just get anticoagulation for nothing, right? So it's very important for you to recognize that one. So as we spoke in the last session, a normal P wave has upright P wave, completely upright and rounded in lead 2, also in lead 1. But then you will see it biphasic in B1, biphasic meaning a little bit positive and a little bit negative, okay? And if you see PAC, the PAC should have a different P wave morphology. Now, if you compare that with multifocal atrial tag has at least 3 P wave morphologies. With pretty much what you're saying is that there's PACs coming from several foci, okay? So this makes it irregular, okay? A flutter usually is regular, but depending on the conduction of the AV node might be irregular, right? So A flutter with barrel AV conduction will be an irregular tachyarrhythmia, narrow complex tach. Okay, AFib is the one that you know the most, irregularly irregular RR interval with no discernible P waves. It's very important that you know that it's non-discernible P waves, because many times I've seen people like, oh, but this little thing, isn't it a P wave? It can be atrial activity, but it's not really a P wave, which again has its own amplitude. Okay, it should be high enough for you to really call it. Meanwhile, regular complex tach might be the one that it's more difficult. Okay, so you have sinus tach. Again, it will be just your regular P wave morphology, and you'll see it in sinus tachycardia. Obviously, there is an upper rate limit that you will be thinking, okay, this cannot be sinus tach, it's going too fast, right? But a patient that is septic, even if they are older, they might be even higher than their maximum predicted heart rate. If you remember, that formula is 220 minus your age, right? So anyways, if somebody who is 20 years old, they can go as fast as 200 beats per minute and still be sinus tach, okay? Sinoatrial reentry tachyarrhythmia, you won't really see much, okay? I actually haven't seen this one yet, but in general, what you're seeing is that you will only see the same morphology as sinus tach. What is happening is that there is a reentry in the sinus node, so you'll be having the same morphology, but the difference is that sinus tachycardia usually goes slowly up, right? If you see that trend of telemetry, and then whenever you fix whatever the patient has, goes down. This is the heart rate trend. And when it's sinoatrial reentry tag, you'll see the patient was a sinus, and it goes very fast up, and then at some point when it breaks, goes down. So that's why it's very important for you to see the telemetry rate, okay, the trend. Then we'll talk about orthodromic AVRT, AVNRT, focal atrial tach, okay, but also very important how to differentiate it from all the other ones, especially flutter, okay. Injunctional tachycardia, injunctional tachycardia is usually in pediatrics, okay. In adults, you shouldn't go more than 130 beats per minute. So unlikely you'll see it. Unlikely you'll see it as something that is actually making the patient unstable. That's important. Okay. Let's see. So yeah, this is just for the, let me just delete this. So just for you to see how the PUA morphologies were, which we already talked about last time, okay? So you already know that in lead 2 should be positive, and then in V1, it should be pretty much just biphasic. Okay. So the approach, I'm not going to cover it, but in general, make sure that whenever you're facing a tachycardia, just know who your patient is with a one-liner, just like the cases that I put here. But then look for hemodynamic instability, because obviously if the patient is hemodynamically unstable, you won't be staring at the EKG thinking like, oh, is this flutter, is this atrial tach, or what is this? You have to just act, right? So you go through ACLS asking yourself those 5 questions as usual. But anytime that you see someone unstable, you need to make sure it's not sinus, okay? Because if it's sinus tachycardia, the patient who's unstable, it might be just septic shock. You won't shock that, right? If you shock that, you're just harming the patient. And this is probably the most important slide of the lecture, okay? If I were you, I would just take a picture of this right now and then use it for the cases that we're going to go through. Okay, but I'm going to also put this here before you take the picture, okay? So when you're facing, again, narrow complex tach, you want to think about, is this an irregular RR or is this a regular RR interval? If it is irregular, we already went through the irregular ones. It's very easy, and we will see examples of each, okay? In regular rhythm, this approach that I have here is both clinical and just EKG wise, but as we're only going to be seeing EKGs, you won't have this option of Pega maneuvers, adenosine, right? But if you see P waves, then you're going to ask yourself, is this sinus, yes or no? Okay. So if it is sinus, just look for what's going on, right? The patient might be having GI bleed, might be septic, might be anything else, just anemia, for example. Okay. And if not, you actually have to ask yourself, what's the RP interval of the patient? And so the RP interval, as you can see here, I'm showing you an RR interval, and I'm showing you what an RP interval is. It's from the beginning of the QRS, you measure it to the beginning of the P wave, okay? And then you compare that to your PR interval or with 1/2 of the RR interval. So a long RP means that the RP is greater than the PR or greater than 1/2 of the RR interval. Okay, a short RP would be basically that the RP is shorter than the PR. Okay, so sinus tachycardia, like in this example, is a long RP tachycardia, right? But you should be able to know if it is sinus before asking yourself about the RP interval, right? So that's why I don't have it here in the lower portion of the schematic. But anyways, in your cases of short RP tachyarrhythmia, you should ask yourself, is that RP as short as 90 or less or more than 90? Why? Because that will give you the differentiation in between orthodromic AVRT and AVNRT, and we will explain why. Meanwhile, in the long RP, you want to see what's the atrial rate. If it is going more than 240, 250 beats per minute, the atrial rate, then it's a flutter. If it is less than 180, it will be atrial tach. If it is between 180 and 240, it can be any of the two. So you'll see many times we say in our notes, narrow complex tachyarrhythmia, likely a flutter versus atrial tach. Okay. Now in real life, you're going to be using a lot of adenosine, which is nice, especially at nighttime. Everybody's like freaking out, but it's nice. This is running out of battery. So now we're going with the cases. We just needed to go through that introduction because I think that without it, you might have been a little bit lost. Depends on what you knew from baseline. Okay, so 50-year-old male with hematemesis. So let me see, where am I going to pick on? Errol Moras. I don't know if I said it correctly or.
Yeah, that's right. Hi.
Too Hispanic of me. I said it with the R's.
Hey. All right. I can start. So looking at lead 2, it has a P wave. So I would assume like sinus.
Okay, so lead 2 is upright, and then which other lead?
But V1 as well, yeah, biphasic.
Yeah, correct. Looks biphasic, right?
Yeah.
Does it fit with the clinical presentation that I'm giving you?
Hematemesis. Yeah, I think so.
Correct, right? I mean, the patient is having GI bleed, upper GI bleed, very likely getting unstable, right? The first sign of shock would be tachycardia. But in general, I want you to approach each one of these EKGs the same way. So you tell me like tachycardia, narrow, then you're going to tell me if it is regular, right? This is regular tachycardia, right? The
Yeah.
RR interval is regular.
Yeah.
And the next question is, do you see P waves? And we said yes, right? And then the next question was, are these sinus P waves? Which is the case, right? So
Yeah.
here, I'll just show you. Okay, so these were the options, but this was very straightforward.
Yeah. So sinus tach.
And then this is what I was telling you about. So you have narrow complex tach, regular rhythm, visible P waves, yes. Is this sinus? Yes. So you just look for the underlying, which is already stated in the vignette. Okay. So let's go and do the next one. Let's see. Rash, Grewal. So I'm sorry.
Yep.
Just before that, I'm just showing where the P waves were. Okay. And showing you again how the sinus P waves are. Okay. So what do you think about this one, Raj?
I don't really see discernible P waves before the QRS and lead 2.
So how about so first thing, is it tachy or no?
Yeah, it's tachy.
Okay. Is it a regular rate or is it irregular?
It's regular.
Yeah. Okay. So the next question, yeah, do you see P waves? Yes or no?
No.
Okay. So this one is a little bit tricky. So anyone else who wants to jump in and just say if they see P waves and where do you see them? If not, it's fine. We can just go through together.
Or I guess there may be P waves there, but they look pretty like then but for the interval, the PR interval would be prolonged.
So
I think
like this one, right?
I think these are retrograde P waves because are buried by the rhythm. I mean, it's a very fast rhythm, so it's buried in the you know the tracing.
So yeah, basically both of you are right in the sense that if there is a P wave, it looks like the PR is very long, right? And it's basically buried within the QRS at the very end. Actually, you can see it here. This is what they call pseudo S waves in the inferior lead. Sorry, you can tell again. If you were in my last lecture, I told you already that I have essential tremor. So there you go. But anyway, so the point here is that you can see some atrial activities happening right after the QRS, right? And when you see this particular pattern, which is pseudo S waves and pseudo R wave in AVR, pseudo R prime in V1, all of those things go along with AVNRT. Now, most importantly, we'll go through the algorithm. Okay, so let me just what's going on. So these were the potential answers that I was giving you. Okay. So narrow complex, right? We said it's regular. We said P waves. Let's say that you would have said, I don't see P waves, right? Which happens a lot. And I would agree with Raj. In real life, I would have just done either vagal maneuvers and or adenosine, right? So adenosine, you usually do 6 and 12 and then another 12, right? But if it breaks into sinus, then you know something was going on there, right? You need to see how it terminates and blah, blah, but I'm not going to go through that today. But in this case, we're saying that this might be the P waves, right? They are at the very end of the QRS. So if you measure your RP, which is from the beginning of the QRS to the beginning of the P wave, you would agree that this is very short, right? Especially compared with the PR interval, right? The PR will be from here to all the way here. Or if you want to just do the half of the RR interval, you know that it's also less than half of the RR interval, right? So that tells you that it is a short RP interval. And if you measure it, you can tell right away that this is less than 90 milliseconds. So it's very important because if you go to CCU and they ask you like, oh, is it very short? How short? If they tell you 70, that would be 70 milliseconds is actually in the EP study, the HV interval. So if they tell you that, you have to tell them in 12 lead EKG, the cutoff is 90, okay? And that way you can just shine if you want, okay? But anyways, 90 milliseconds is very important. Why? Because it gives you, this is AVNRT, not really orthodromic AVRT. And we'll talk about both after we see an example of each. But anyways, I'm pointing out here where the P waves were, okay? So remember, pseudo S waves in inferior leads, pseudo R prime in V1 and pseudo R in AVR are diagnostic for AVNRT. The reason being it's so short, the RP, that it's pretty much within the QRS. Okay, so AVNRT, retroventricular nodal reentry time. Let's see here. Highs. Let's do this one.
Hi. So this is a narrow complex tachycardia. Let me say it's regular.
Yeah.
I don't see P waves on lead 2.
Look closely, just like in the prior one, look closely
Yeah.
what happens after.
Yeah, maybe just after. Let me see V1.
After which leads would you say you can see something happening?
Yeah.
Let's go to inferior leads. Do you see anything happening after the QRS and before the T wave?
Yeah, it looks like it's after the QRS. It's just,
Yep. That was
Yeah.
supposed to be a circle. I don't know
mhm,
what happened. Looks like a moon. Anyways. Yeah, so right after the
Yeah,
QRS,
relevant.
right, you can see
mhm,
what someone else called retrograde P waves. But retrograde P waves actually are defined as basically inferior leads being negative because they are coming from below
mhm,
up, right? So they are going away from the inferior leads. Okay,
Mhm.
so you can see it here. So coming back to that algorithm that we saw, what would you think this is? Is this a short RP, long RP?
It's a short,
Short RP, okay. And then the
Yeah.
next question would be, does this measure less than 90 milliseconds or 90 or more?
looks like less than 90.
So it's from the beginning of the QRS, right? So
Yeah,
if you measure from the beginning of the QRS, it's almost like at the limit. But in general, this one
Yeah.
is actually measuring
mhm,
100 milliseconds. So you have to really look into it, right? But if
mhm,
it is more than 90, then instead of being
Then it's
AVNRT, which one would you pick from these options? Let me see.
If it's longer, then it is not. Sure.
So I placed it without the acronym, so that way you know which one is which,
Yeah,
right? So this is atrioventricular reciprocating tachycardia. Sometimes misnomer as reentry tachycardia. It's
Okay.
called reciprocating tachycardia. So this is
Mhm.
AVRT, orthodromic AVRT. Okay, so I'm showing you here again where the P waves are, right?
mhm,
Okay, and they are just going back to this one again.
Okay.
You can see how the question was, do you see P waves? Yeah. Is this sinus? Definitely not, right? It's negative in lead 2.
Mhm.
Okay, the RP interval was short, and then you measure it and you say it's 100 milliseconds, so it will be
It's more.
orthodromic AVRT, right?
Mhm.
That
Yeah.
clear? I know it's a little bit difficult, but the more you see, the easier it becomes, and the more you use this algorithm, the better it is.
Mhm.
Okay, so
Okay.
let's see the explanation for both. Okay, so AVNRT and AVRT are actually the ones that people call SVT. The problem of calling something SVT is that you're basically stating literally everything that we talked at the beginning, including the irregular tachyarrhythmias, because SVT is pretty much supraventricular tachycardia, right? So everything that we talked about in that huge algorithm is included in that statement. But if you say PSVT, paroxysmal SVT, you're actually talking about these two, okay? So these two are AVNRT and AVRT. So AVNRT is atrioventricular nodal reentry tachycardia. And it's very important to know that that's the most common one. If you see a paroxysmal SVT, 80% of the time it's going to be AVNRT. Okay, it's more common in women and it's more common to happen in young women. So 25 to 35-year-old. And meanwhile, AVRT, you need actually to have an accessory pathway. So that's why in the vignette I was saying that at baseline, the patient has Wolff Parkinson White. And that's why also in that algorithm that I made, I have like after seeing what happens with adenosine, if it breaks and you see delta wave, then you can say more likely orthodromic AVRT, right? So accessory pathway, I'm not going to go through what's the difference in between manifest, latent, and concealed. You can look for it, but it's not extremely important for you to know, okay? But what is important to know is that orthodromic AVRT is narrow complex and antidromic AVRT is wide complex. I'll explain why. We'll talk about first the pathophysiology of AVNRT. So AVNRT, on the left side, I'm showing you what's happening in a normal beat. It's important also to know that even 10% of people have what we call slow pathway and fast pathway, so a dual type of conduction around the AV node. It's not really happening inside the AV node, but it's around it. Okay, so what happens is that you have your impulse from the SA node. Obviously, you're depolarizing also your atria, but then when you reach your AV node, these 10% of people will have a fast pathway, which conducts fast, but it actually repolarizes slowly, and a slow pathway, which conducts slowly, but it repolarizes faster than the fast pathway. A very important concept. So what happens when you have a regular beat coming, you go through both the fast pathway and the slow pathway. Obviously, the fast pathway, as it conducts faster, gets through and passes to bundle of His faster than the slow pathway. So the slow pathway conduction, what was coming here, finds this area already depolarized, so the impulse dies there, right? So nothing happens, you just have a regular beat. So think about what could happen in the setting of a PAC or even in a PVC setting, it can happen. In a PAC, like in this schematic, what you might find is that the fast pathway, even though it's faster to depolarize, is really not fast to repolarize. So a PAC might find that not repolarized yet, having again a unidirectional block here, but going down the slow pathway, which is already repolarized, and because it goes so slowly through it, by the time it reaches this area, it's able to conduct retrogradely, but also to the bundle of His. So you're going up and you're depolarizing the atria, besides creating a reentry. And the reentry maintains because the slow pathway is so slow that anytime that it conducts here, it will find this again repolarized and able to just do this loop. Because a loop is happening in a very small area, and it's depolarizing basically both things at the same time, meaning atria and ventricle, you will have a very, very short RP interval to the point that it's less than 90 milliseconds. And that's why you have that in the schematic, okay? Compare that to what happens when you have an accessory pathway. So in a regular sinus no beat, in a patient who has a manifest accessory pathway, what you would see is that there is conduction through both the accessory pathway and the AV node. Given that the AV node has its own delay, then you will see that in a normal EKG, you will see a PR segment, right? Meanwhile, when you have an accessory pathway, by the time it gets there, there's no delay, it just goes through the ventricle, but it goes slowly, right? Because it's just depolarizing the ventricle through gap junctions. So that's why you see a slurred depolarization at the beginning, what is called delta wave. By the time that the AV node already allowed the impulse to pass, it goes into the bundle of his and Purkinje fibers, then it depolarizes quickly. So that's why the only area that it's actually widened is the very beginning of the QRS complex, which you call delta wave, and then you see the regular depolarization, right? So think about what happens if you have, again, a PAC or a PVC. So these two also will have different repolarization rates. It depends on each patient. So it's not like the other one that the slope pathway for sure will be the one repolarizing faster. But the point is, if you have a PAC and you find either of the two not repolarized yet, then you will only conduct through one of them. And then it depends on the accessory pathway if it can conduct from ventricle to atria or not, and also the AV node if it's able to conduct from ventricle to atria, which is not uncommon. But the point is, if you have a PAC and these loops is generated, it depends on where are you depolarizing your ventricle from, that you will see a QRS that is narrow or wide. So if you're depolarizing your ventricle through the AV node, his Purkinje fibers, then you're going to have a narrow QRS complex, which is called orthodromic AVRT, because you're depolarizing then the atria through the accessory pathway. And because this loop is way bigger than the one in the AVNRT, you will have an RP interval that is still short, but it's not as short as 90 milliseconds or less. Okay. Then in antidromic AVRT, which we're not going to cover today, is just wide complex because you're depolarizing your ventricle through gap junctions, as you can see here, because you're depolarizing through your accessory pathway and going back up through your AV node. Okay, so I hope that was clear. Very important concepts in pathophysiology. Okay, so let's see. Click on Murillo Bastos. I'll continue doing it Spanish way, because Sananda here direct message me that I'm translating all the names to Spanish. You need to unmute yourself, Murillo, or Murillo.
Murillo, okay.
There you go.
The first step is narrow complex tachycardia.
Yep.
The rhythm, I can see.
Is it regular?
Regular.
Yeah. Okay.
P waves. Oh, it's hard to see these P waves.
Yeah, it's not the same to have the paper in front of you, but that's why I tried to enlarge the EKG as much as I could.
Let me see. Did you? Yes, I can see some.
Yeah, lead two, where would you say?
D3, D2 and D3. I can see some P waves.
V2 and V3, you said.
D2 and D3. I can see
Okay.
some P waves after the QRS. But it's hard to see.
Mm-hmm. But then you're calling on these things that you see here, I assume. This one.
Yes. Yes.
Good, good. So that's great. But the thing also here is, one of the major things that you need to also think about is what's the exact rate that you have. And this one is going more or less at 150, 160 beats per minute, right? When it's going at that rate, you want to make sure that there is no like a 2-to-1 type of conduction. Okay, so this one is a tough one, but I'm making it because it happens quite a lot. This is a very common one to see. Okay, I'm just trying to, so these are the options that I'm giving you. If you would have to pick one of them, which one would you pick?
I will say that Stachy is regular. I can see P waves here. So sinus, maybe. Yes.
So if you would say sinus, you would have to really have like an upright P wave here in lead two, right? And this P here in V1 should be biphasic.
Mm-hmm.
Not that it cannot be, right? But here I mostly see a positive portion, right? So coming back to this, right?
Mm-hmm.
We're saying that there is a P wave. The question is, where is that P wave and how many P waves are there per QRS complex, right? So the most important thing is to determine what's a T wave and what is a P wave, because it's very difficult sometimes. But the trick, to me at least, is that you should pick on the T waves that are in V2 and V3, because V2 and V3 will usually have the tallest T waves. Okay, so those are the T waves,
Mhm.
the ones that I'm tracing here, right? And you trace it down because in general, the EKG is a 10-second snapshot, right, of the patient's rhythm, right? And everything from left to right, basically at any point that you cut it vertically, it will be happening at the same time, right? So the T waves are here. So you know because of that that in lead 2 the T wave is mostly flat actually, and this negative thing is your actual P wave, okay? Which you can see part of it here. You see how you don't see the full P wave
Yeah.
in the first beat, but it's there, right? It's a tricky one, but in general, you're seeing a 2-to-1 conduction, okay? And usually flutter presents as a narrow complex tachyarrhythmia in 2-to-1 fashion that is going to go at 150 beats per minute, because the majority of the times flutter is going at 300 beats per minute when the atrial rate. So here you're going to be, let me see this. Sorry, I'm just trying for this to show there. Okay, so it's showing you how in lead 2 is where you see them better, but if you also pick on V1, it's actually a little bit negative and then positive, that P wave, and then here you're not really able to see it, but that's where it should be, right after the QRS, okay? So this is a 2-to-1 HO flutter. Why is it HO flutter and not HO tach? So you're saying long RP, and the reason that we're saying long RP is because the one conducting is not this one right after the QRS, but it's the one before the QRS, right? And if you measure the RP from here to here and the PR from here to here, you will know that the RP is a little bit longer than the RP. That the RP will be a little bit longer than the PR, sorry. Okay, so as it is long, your next question was, what's the atrial rate? And because you know that the ventricular rate is going at around 150, 160, and the conduction is 2-to-1, then your atrial rate is double of 150, 160. So it's going in between 300 and 320. Atrial tachycardia is not able to go faster than 240 beats per minute. Reason why this would be atrial flutter 2-to-1. Okay, let me just erase that. Hope that was clear. Was probably the most difficult. Okay, but great job. So let's see the next one. Well, atrial flutter, just a couple of slides of it. Basically, you usually see a sad-tooth pattern, but the way to see the sad-tooth pattern is it depends on if it is a typical A flutter or not. It also depends on what's the rate of the patient, because the faster they go, the more difficult it is for you to see the atrial activity. But if somebody ever asks you, which very likely will happen, it's a macro reentry tachycardia. Okay, so it's a huge loop that is happening in the right atrium, usually around the tricuspid annulus. And it's important to know that in the slow zone of that reentry is called cavo-tricuspid isthmus. So basically, that's where we ablate, because it's the easiest area to ablate. It is right next to the AVC, so we just go through with a catheter and do radiofrequency ablation there. It's the easiest one to ablate. It takes like 15 minutes compared to atrial fibrillation, which might take up to 4 hours, depending on how difficult it is to map it. Okay. But anyway, so very important for you to know that CTI ablation means cavo-tricuspid isthmus ablation, because you might see that in our notes instead of putting the full word. So let's see this one. Let's see. Niha, I worked with you before. Let's see. Let's see.
So this is a narrow complex tachycardia. There are visible P waves in, and it is positive in lead 2. It is not sinusoidal in V1.
Mhm.
It is also positive in V1, so I'd not call it sinus.
Mhm.
So this would be, I mean, going by the algorithm.
Correct. So you said, so far you've said that it's a narrow, complex, regular attack, right? You saw P waves, they are not sinus, okay?
Yeah.
So the next question is this the RP, is it long or short?
The RP is, I'd say, long.
Yes, right? Because you're measuring basically, so just to make sure that you all understood well, you're measuring from here to here, and you're comparing it with the PR, right? So it is longer than the PR. Okay, so that's pretty much what you call long. Okay, now that you know it's long,
I mean, if it's long, it could either be atrial flutter or atrial tachycardia.
so the question is, what's your atrial rate, right?
The rate is around 300.
So the rate, because you're conducting one-to-one here, right?
Mm-hmm.
There's one P wave per QRS, right?
Mm-hmm.
And then you're seeing that the atrial rate is the same as the ventricular rate. The ventricular rate is going at basically 150 beats per minute.
Yeah.
Right? So it is less than 180. So you would say it's atrial tach.
Right.
Okay. So we're gonna speed up a little bit so that way we can finish. And so from now on, I'll be saying it out loud. This ones are actually easier. That's why I left it for me. So 78-year-old COPD exacerbation, typical step 3 question, hypoxemic to 86. You see here, narrow complex, irregular tachyarrhythmia. And you look for the P waves and you can see that there's several morphologies. This is negative, it's a little bit positive, a little bit triangular. This one is more upright. This one is like biphasic. This one is bimodal. There's so many morphologies. So greater than 3 morphologies in your irregular narrow complex tach and also a PVC here, right? So this will be multifocal atrial tach. How do you treat it? Give the oxygen, correct electrolyte abnormalities. Okay? So from the irregular rhythms, as I was telling you, those are the easiest ones. Okay, so MAT and a PVC. This one, oh, it's lagging, okay. This one, I'm saying that the patient overdosed in one of his meds. What we actually did was that we gave adenosine, and this is what happened. So here you can see very nicely your sawtooth pattern, right? But then if you see the RR interval is very irregular, especially here at the very beginning, it's a lot longer than what happens in the middle, right? So this is what we call atrial flutter with variable AV conduction or AV block, okay? It's also important to have it in differentials when you have a narrow complex irregular tachyarrhythmia. This one is the one that you'll see the most the most, at least in cardiology rotations. So 70-year-old OSA, hypertension, diabetes, hyperlipidemia, palpitations. And then you see irregular, narrow complex tach with no discernible P waves, right? Because if you really look into it, you might say like, well, what's up with this? Does this mean anything to you? No, pretty much these are just whatever you see that it's coming from the atria. If you actually see it, then you will call it fibrillatory waves, okay? This is your typical AFib. And then let me see, I think we have one more. No. So we'll just do the post-assessment. So this again is the most important slide, right? If you use this is not perfect. I made it just to make it simpler. But it actually covers at least 90% of the time. If you use this for a narrow complex tach, you get to the diagnosis, okay? So let's just go through together with the post-assessment, okay? So 45-year-old asymptomatic, poorly controlled hypertension is pretty much the same that we saw before, which was the most typical EKG. Again, when you see a narrow complex tag that is going at around 150 beats per minute, you really have to think about 2 to 1 flutter. Okay, and if you, let me see if I click here, yeah. So, but in this case, sorry, this is not 2 to 1 flutter. This, you can see here, you can see the pseudo S waves at the inferior leads. You can see the pseudo R prime in V1, okay? So in this case, even though it's not your typical age, right? It's 25 to 35-year-old females are the ones who have it the most, but this is the most common of the PSVT, so this is ADNRT. Okay, so always go back to that algorithm when you're seeing this. This other one, this is the one that I was thinking about before, sorry. So 59-year-old female, hypertension, diabetes with palpitations. You can see upright P wave here in V1, right? Definitely not a sinus beat. You can see also at the very end of V1 that there is an atrial activity as well. So this is a 2 to 1 conduction. And because it's going at more than 240 beats per minute, the atria, then it has to be flutter and not track. Okay. So that's the T wave I was showing you, so 2 to 1. So 2 to 1 A flutter. Okay. This one is the one that you'll find the most in your telemetry rotations, and you won't call me for a consult because now you will know that this is sinus. As you can see this beat here, very sinus, right? Very sinus beat. You can see it's upright P waves in lead 2, but then you see that some of the QRS, I mean, in general, it's an irregular tachyarrhythmia, but you can see that the P waves are not always the same morphology, but it's only one morphology extra that you see. Reason why this is just your regular sinus tag with PACs. Okay. So you can see there the 2 types of morphology, the sinus one and the PAC one. So this one, I just place it as a trick because if you see it very from far away, you might be thinking, oh, this is regular. So this is flutter with somehow a regularized rate. So you might be thinking like 4 to 1, 3 to 1. But if you see closely, you can see that this one is, this RR interval is way smaller than the other ones, right? And in general, it's not really fixed. So this is A flutter with variable AB conduction, okay? And it's not 3rd-degree AB block because your actual flutter wave to QRS maintains the same interval. So you know how we have PR interval, there's also flutter to QRS interval, okay? So if you measure that, if you see a patient that is like very, like that you know that the patient has flutter at baseline, but you see them very bradycardic, you have to have in your mind, maybe this patient also has a 3rd-degree AB block that nobody has picked up, okay? So you need to measure that interval. If it is not constant, then it might be 3rd-degree AB block. So this, I'm showing you how they were different RR intervals. So a flutter with variable AB conduction. So last slide. So take home messages. In general, anytime that you see a tachyarrhythmia, now after this lecture, don't be thinking about, I will always do the algorithm, right? The first thing is that you need to make sure that the patient is not hemodynamic and stable, right? Because when they're unstable, it's the easiest thing to know what to do next, right? You have a hemodynamic unstable patient that is not a sinus tag, you just cardioverse, okay? So just act per ACLS. But in general, if the patient is stable, then you will do the usual. You will say, is this narrow? Is this wide? Is this regular, irregular? And then look for the P waves, right? In general, you have to just follow a systematic, but also clinical approach. I will recommend that algorithm for now. Whenever you read a little bit more, you'll see that the algorithm is not 100% all the time, but it actually guides you a lot, okay? But in general, any time that you have this, just rule out sinus tag. Think always about who's my patient, what's my clinical scenario. So those are just reading material if you want to.